and welcome to our 23rd episode on My Matters. My name's Ethan.
I'm Ben.
I'm Kabir, and today we have a very special guest, Dr. Holly Wilcox from Johns Hopkins University. Dr. Wilcox is the president of the International Academy of Suicide Research and is a professor at Johns Hopkins Bloomberg School of Public Health. So today's episode, we'll be talking about suicide prevention and how disparities in access to mental health care can impact outcomes of suicide. So I'd like to begin with the question of your experience in mental health. How would you describe your role as an educator and researcher at Johns Hopkins?
Thank you so much for having me in this episode. I'm so happy to be here talking with you all. So I have been working in the suicide prevention research area since 1992. So my courses, mentoring, public education, and training efforts have been focused on the current and the next generation of public health officials and people working in the mental health and suicide prevention research or clinical areas. My work is right at the intersection of public health and suicide prevention.
So, of course, suicide is, integral to a great deal of research. So, kind of what affected your perspective on kind of the impact of disparities in mental health care the most when, considering suicide? Given your research, one of those publications is about disparities in particular. So I was just wondering, how did those kind of intersect for you?
Yeah, I've always gravitated to the most complex and challenging public health problems. And when I was just entering the field of psychology and public health, it was around the time when Surgeon General David Satcher declared suicide as a major public health problem back in 1999. And so when I was just entering the field, that was going on, and I was just kind of taken by it, kind of looking at the data and the trends and thinking, this is a really complicated problem where I just can't see a lot of easy solutions to this. So we need people who are going to really focus on making an impact in saving lives in Americans.
Yeah, so it's interesting to me, or it gets me thinking about, like you said, one of your main goals is to mentor the next generation of public health officials to solve these problems, right? But you also said you're gravitated to complex, um, the most complex issues with a ton of factors playing into them that probably take years to study. So how do you kind of bridge solving these or thinking about these complex issues that I maybe may even challenge you, but also mentoring people at the same time who are just starting to comprehend and think about public health?
Yeah, Ben, that's a great question. I feel like I've been around for so long that I kind of know, kind of the problems, and I know the things that people will encounter that could burn them out or that could make them discouraged. And so a lot of times the role that I play is a cheerleader. It's like, you can do it. And, kind of just encouraging and, because it's easy to throw in the towel when you're not seeing a direct impact of the work that you're doing, or if you're feeling overwhelmed by it, or there are aspects. Sometimes when you're in this field of suicide prevention and you're interfacing with families, it's really sad. And like you'll want to cry in front of the family, or you'll feel kind of really triggered or traumatized by what you've heard. And so a lot of time my role is to try to build resilience in young professionals so that they see the big picture, like this is so important. And there will be things that you encounter that will be hard. But the end goal is where you gotta keep your sights on the end goal so that you get there and not be set off track by things along the way that could take you off track.
Mhm. In terms of disparities in mental health treatments in different locations or groups of people, I was just wondering, in terms of like the word disparities, does that mean access of care, quality of care, outcomes of care? What does that like disparity really look like?
Yeah, that, kind of disparities has been sort of a catch-all. And the way I think of disparities are really health disparities because I'm a public health professional. So I think about health disparities refer to differences in health status, disease burden, access to healthcare services, quality of the healthcare services that are provided, and outcomes between different groups of people.
Mhm. Do like specific groups experience that disparity more than others?
Yes. In the suicide prevention space, the data have been more flat for white Americans. And one thing that we see, if we just look at our overall statistics, the disparities are hidden. But it's if we kind of stratify and we look by sex or we look by race, we look by age group, or we look by geographic location or socioeconomic status or LGBTQ plus status, that's when we see these glaring disparities in the data. One example is Native American and Alaskan Native individuals in the United States. They have, in some communities, not all American communities, in some Native American communities, we see like a 2 to 3 fold increased risk among teenagers
Mm.
as compared to our overall statistics in the United States.
So when you talk about disparities, could it mean something other than like a resource or like monetary based discrepancy? Could it be like related to like the rhetoric or stigma around mental health in different communities? Like, do disadvantaged communities potentially like have less time or less effort to like spend on mental health issues? Because we talked about with our last guest, Sam Saban, who worked in the Chicago public school system. She talked about a lot of kids in the communities being in survival mode. So it was harder to focus on public health. And also, like in our community, I think a lot of times, schools like want to talk about mental health, but they don't do it in, the best way, and sort of like talking about it in like a lighter way kind of trivializes the issues that we see in our community, which is one of our goals to alleviate. So both kind of like negatives there. But how do you could rhetoric and could stigma be part of the discrepancy or disparities in mental health?
Yeah, that's a great question, Ben. I mean, the one thing that we have to think about are social determinants of health, like you were referring to. Like if people don't live in safe housing, they haven't eaten in days. They haven't had anything healthy to eat in days. They can't earn a living wage. They can't provide safe and affordable childcare to their kids. Um, and they're living under the threat of domestic violence or in an extremely violent neighborhood, or they're so socially isolated that they just don't have support. How can we expect a person living in those circumstances to benefit from cognitive behavioral therapy or any other evidence-based treatment that we have available? We just can't expect it. And so that's why a lot of the kind of the policy efforts that we're seeing recently are kind of trying to address social determinants of health, to try to give an hourly minimum wage that's enough for people to actually be able to live and eat and get a safe house and things like that. And those types of policies have a downstream effect on suicide. There was just an article by Jonathan Purtle who examined all the policies in the United States that are linked to suicide, and they fall into three buckets in his work. It's lethal means, social determinants of health, and access to mental health care. And so he reviewed across those areas and found an impact on suicide. And so, maybe the average person may not think of social determinants of health. So that's why I'm glad that you guys are shining the light on this issue because it's so important.
Mhm. That's fascinating. Definitely the kind of survival mode. I think, yeah, Ben was referring to that as, when you're experiencing all of these challenges in life, it can be more difficult to set aside the time and resources for proper mental health care. That's obviously a reality that many communities have to face every day and that, many people might take for granted. So particularly, surrounding suicide, you mentioned kind of the downstream effects of mental health care and suicide. I'm wondering more like um, how does prompt mental health care, or how does seeking, or how do how does prompt healthcare help marginalized communities specifically in terms of suicide outcomes, like in terms of the statistics? Like, has there been research on the effects of getting that kind of treatment into these communities that are kind of in a state of more survival, rather than dedicating those extra resources to mental health? Or just how does suicide and those marginalized communities, how does that like intersect for them?
Yeah, and it's a really good question also. I think we've taken a really paternalistic approach to mental health and other areas of health where we think we know what works. And oftentimes, for communities, there needs to be some cultural adaptation in order for any type of approach we have to offer to really maximally benefit a person. And so I think one thing we need to be able to do is do that cultural adaptation, and we need to listen to people with lived experience from historically marginalized communities. We can't assume we know all the answers. We don't have all the answers. So we need to learn from the people we serve. So we need to know like what would work for you, like what would be most beneficial. And that's what we've kind of done in some of our programs that we've implemented in the schools. Like we'll take, okay, we know these programs are evidence-based. So we take a short menu to the school system and let them decide of these evidence-based options what they think is the best fit for their students and what's going to have the most impact and what's going to be sustained and what is really going to make a difference. And
Yeah,
is,
sorry.
oh, go ahead,
Sorry.
sorry.
Um, I wanted to emphasize like your point about listening versus talking, and how important it is to listen and not just talk about mental health, which I understand is ironic because this is a podcast of just, us talking. But you know, in our communities and our schools, we've talked a lot about how people like almost like self-diagnose. They'll be like, "Oh, I'm so OCD. I'm so, all these things." And that's sort of, we talked about, it's sort of good that people are talking about it and recognize that these issues exist, but it also marginalizes and isolates people and kind of takes the amplification out of their experiences, and in that way, they may feel socially isolated or isolated from getting help. So it's important to offer an environment where people can talk, and we listen to their experiences, whether it's a friend, whether it's a community, a specific community in terms of location, or a community in terms of like you said, the factors like race, sex, sexual orientation, anything like that. It's much more important to listen than like you said, just keep on talking about it and taking a paternalistic approach. Um, I wanted to ask, you said that um, social policies that improve social factors, like you said, minimum wage, so people can have, a safe home, safe environment. Those have, you said, a downstream effect on mental health care because then people can allocate more time. So my question is, um, does that social policy have to come first before, policy that helps, mental health care comes in, or can those two happen kind of at the same time?
Yeah, so that's also another really good question. I think we have to be taking a comprehensive view of this issue. I don't think there's going to be one answer. It's a complicated problem. And so I think if we're looking at what's evidence-based for lethal means, like we should have maybe child access prevention laws, or, in some states where it makes sense to do so, extreme risk protective order legislation and things like that, background checks. A lot of the gun policy that's out there has a decent evidence base because suicide's an impulsive act. And if somebody has easy access to a firearm or stockpile pills or other types of lethal means, their risk is threefold higher of making an attempt when they're in crisis than if somebody has barriers to them accessing a lethal means, an approach to lethal means. So that's definitely common sense. I think a lot of those policies, depending on the cultural context of the state and the community, they will work in some places and they won't work in other places because of people's views in those states and their need for, privacy and other things like that. But so, the gun laws I think are important. I think the social determinants of health are critically important as well. So we should be thinking about sort of the best package of policies that can fit within a specific state. And also thinking about mental health care access, which is a big deal because sometimes the waiting time to get an appointment with a mental health provider could be months. And people get discouraged while they're waiting and think, you know what? I don't know if this is worth it. And so there's that issue. And then once people get to a provider, they may not feel as if their needs are being met, or they may not, for whatever reason, it may not seem to benefit, or an evidence-based practice may not being implemented. A lot of times people think that all mental health professionals know how to do a suicide risk assessment. And the bottom line truth is that a lot of mental health professionals don't know how to do a really high quality suicide assessment, and some of them are really terrified by the thought of having to do a suicide risk assessment when they have somebody sitting in front of them, or sitting, in Zoom or in person, that they think is at very high risk to end their life. And so I think when we think of policies and programs, we have to think about the needs of the community, and we need all of what will fit for that community. So some level of a sort of needs assessment, like knowing what your population is and knowing what could benefit your population, and be because we can't just take a one size fits all in the United States. We're a diverse, country, and we have a lot of, and so we have to come at it thinking about our own community and the needs of it, and then getting those policies and programs in place that meet the needs of the people and can be sustained.
Mhm. And in terms of the cost behind mental health treatment, I know it can be pretty expensive and depending on insurance and stuff, but in terms of as a society and, state governments, national governments, are we moving towards more funding towards mental health? Like, what's the general trend of that?
Yeah, I think if you would ask a lot of people, they would have a pessimistic view that our mental health system is somewhat broken.
Mm-hmm.
And we need to maybe think about other countries and contexts where you see that they have a different system of care. Like if you look at Europe, some of the countries in Europe, like a good example is Denmark. They have universal access to health care. And they have done a great deal of a sort of an investment in suicide prevention. So one thing that they've done is say, okay, what works for suicide prevention? And let's see what's going to work for Danish people. And then they rolled it out. They made an investment and they rolled it all out, and they saw a dramatic, they've been seeing a dramatic decrease in their suicide rate. And Ethan, you may be thinking like, well, why don't we just do this here? And in the United States, a lot of the states have their own authority to make their own decisions. And, Denmark is about the size, I think, of Maryland. you know? And so it's kind of like easier to do something on a smaller scale when you think about the diversity and like the authority that each state has in the United States. It's hard to carry out something national like that, even though it would be wonderful if we could. So, so that's the challenge that we face in the United States in some respects is that, you know, with our healthcare system, like I wish I could say that most suicidal people will receive an evidence-based practice, but it's unlikely that a suicidal person will get cognitive behavioral therapy, dialectical behavior therapy, any of the research proven, you know, different types of medications that have shown to be effective. Unfortunately, there is a great disconnect from what the research shows and what's done in the community. So I think the task for your generation is going to be thinking about how to translate research findings into what the community is able to deliver at a very high quality. Like, I would love it if all of our therapists at Johns Hopkins and in our broader healthcare system were all trained in all the evidence-based therapies and delivered them. And I think largely I would say we have that, but we're not the typical health system. I mean, you know, we're an academic medical center, and for some community health systems, they don't have the resources to train all of their providers on the best practices so that every patient that comes in gets the like state of the art. But that's what we want to get to. We want to roll out the state of the art for everybody who comes in to care.
Hmm. So it seems like, a top-down approach starting with like high levels of government, that might be a little tricky, but I think, what we talk about, kind of like this bottom-up approach, increasing more dialogue and like authentic conversation. I think that's a great way we can kind of, encourage people higher ups to kind of focus more on mental health. But I just find that Denmark example very interesting because that you're right. Like I did think like, why don't we just do that if we see those results? But like you said, we're just very divided at times, and I feel like it's hard to come to agreements in terms of where funding goes and stuff like that. But yeah. Mm.
That's why, Ethan, I think it's really important for those that are comfortable doing it to be able to work with the late legislature,
Mm.
you know, and even offering them ideas. Like, you know, this policy has evidence, it's worked in these other places, and this is what we're going to need to do in our state in order to save lives. You know, and the ability to do that can really have a big impact, going to them with ideas and evidence, and even offering to write the bill
Mm.
for them, or working with people who know how to do that can make a big difference.
Mhm. That is, I also found kind of your description of, the way that governments intersect with mental health policy, particularly on, the vast scale of the United States as opposed to, a smaller country like Denmark. That's fascinating. And one of the big, I guess, threads throughout this conversation for me has been the impact of community and tailored solutions for mental health as opposed to, like a general, kind of prescriptive way of doing it for like large, swaths of the population. So, in terms of that community mindset, in our community, we've had, many programs and organizations dedicated to mental health. And, we are in a relatively privileged community compared to many others. And so, obviously, the resources in our community are going to differ tremendously. So, in terms of other communities, like more marginalized communities, what are some of in your experience, what have been some of the best, tools for those communities to be able to raise awareness about mental health at a local level and also help people get the care they need, even in situations where it's seen as less of a priority or people cannot give the same amount of attention or resources to those to healthcare. What are some of those more community-based methods that you've seen have the greatest impact, like organizations or any other local efforts?
Yeah, great question. I think that the position that we're in right now, unfortunately, is that we're a lot of times we're waiting for the person to be sitting at the ledge ready to jump, and then we offer them 988 or something like that that may appeal to them or not appeal to them. And we have to get out of that mindset. We have to get into the community and meet people where they are in the workplace, in schools, in colleges, in the justice system, in other places. We can't wait for them to come into the clinic because 60% of people who die by suicide are never going to make it in to see a mental health professional. So we have to get into the community where people are, whether it's social media or other places. And I have seen some really innovative things lately that I think are worth elevating. And now, where AI is such a part of our lives, we can kind of try to maximize it or leverage it for action. An example is there's one of our 988 centers in Oregon called Lines for Life has an amazing program where, most counselors, most crisis 988 counselors are sitting and waiting for somebody to call or to text. But we know that not everyone is going to do that. So what they do between calls and texts, they get onto social media platforms and they hand search for people who are struggling. And when they find them, they private message them and they do de-escalation, they provide resources and support for the person. And sometimes it's just kind of trying to suss out what's going on with them and how they can help and just, like a sort of a listening type of an approach. And so those types of models can be scaled through AI to help a lot more people. And so I think there are things like that that we really need to be doing. I happen to be a big champion of getting into schools and trying to maximize health education class. When 50 million years ago, when I was in high school, health class to me didn't meet its potential. So what we're trying to do in Baltimore, we're in like 10 schools right now, is we're trying to deliver 5 hours of really high quality mental health education to students. And so we have an evidence-based program that we've culturally adapted to urban youth in Baltimore City. The students helped us with it. They tore the intervention apart. They're like, oh, this slide is, don't say that word because it's cringe. And like all these other things. They told us to change the language, to change the colors, to change the slides, change the role plays. And we changed as much as the developers would let us do. And then we go into the schools and we implement this in 5 hours of time with the students, and we're sort of studying it. And the role that that type of an approach plays is if something like suicide prevention and mental health is delivered in school, it's saying this is an important topic. It's worthy of 5 hours of your time. And everyone should get it. So it could have an impact on stigma. And a lot of times, young people will keep something a secret. Their friend will be staying home from school and will be planning a suicide attempt. We'll tell them, please don't, and they'll say, please don't tell anybody. And if they keep this a secret, it could result in their friend taking their lives. And, so knowing when to go to an adult, how to identify a trusted adult, how to distinguish when something's a crisis from when it's not a crisis. You guys may know all that stuff, but not every student does. And so going in and giving them the basics and the tools that they need to navigate a crisis, when somebody's in crisis, things can snowball and get really a lot worse if you don't know how to approach it and you don't stay calm and you don't kind of have the skills to be able to navigate it. But that's what we try to do in the schools. We try to teach students how to take a deep breath, look at what's going on, and try to use the skills they've learned to approach the situation and de-escalate it and be able to get an adult involved if needed.
Yeah, I think that's such impactful work, and the tailoring it to like students, because I remember like in our health class, like we had like mental health, like something along those lines, but it was obviously not as tailored as you're talking about, and I can definitely imagine like how much more impactful it was. So kudos to like that that really great work. So the next question that I have kind of goes back to your comment about like it being a package of policies rather than one before the other. From a research standpoint, how do you like model the effects of a package of policies that have so many factors, across different communities when you're like proposing them to like a legislature, to legislative people, when there's already so much disagreement about where funding should go? How can you guarantee like that this package of policy, or not guarantee, but how can you like assure that a package of policies will work in a certain way? And the second part of the question is, this is actually coincidental, but this is in the works. I'm not promising like anything, but for our next episode, we're actually potentially going to have a state senator from Illinois on our show. So what should we be like talking about? What should we be recommending?
That's a good question. Um, I think there has to be attention to the evidence base. And so if the policies and the programs that you're proposing have a strong evidence base, especially if they have an impact on preventing suicide at the population level, that's a pretty good indication that this is something that they should look at or consider, if it would fit their population. I don't know that there are any really good examples that exist of a package that has been studied. Because you can't really study like one policy in isolation, because usually in states there's a lot of other things going on. And so right now we're doing at Johns Hopkins, we have a study funded by the Bloomberg American Health Initiative that is looking at doing a landscape analysis of every single state. So we're pulling what passed into law in every state in terms of policies that mention suicide in them or are directed at preventing suicide in the population. So we're looking at them, we're cross-checking those policies to see which have an evidence base and which don't, which are recommended and which, by the National Strategy for Suicide Prevention and which aren't. And then we're also looking at when those policies were introduced and if they actually at the population level impact suicide overall or in any of the specific disparity groups that we were talking about, the groups that suffer health disparities that we were mentioning, talking about earlier in this conversation. So we're looking at different subgroups of people by sex, geography, race, LGBTQ status, if we can get at those data and things like that. And so we're taking sort of a two-step process. We're looking at what exists, but then we're cross-checking with evidence base, and then we're looking at the impact on suicide death outcomes. We'll probably look at overdose too, because there's some overlap there. And so that's the process that we have decided to take. It's a very time-consuming process to get there. But if you have a conversation with a state senator, I think finding out what could be helpful to them. Like if we all want to prevent suicide at the population level, and we know what works or what we think works, what is the best way to work with them to have an impact? Is it through, working with them on specific bills, or is it, on writing grants to try to get funding for these things? Because oftentimes bills are passed into law with no funding attached. And the other thing is that these bills by themselves or these laws by themselves, if they're not implemented well, may not have the impact that we would all want to see. A lot of the success is in the quality of the implementation. So, with the red flag law, if the police are supposed to be delivering the orders to take away people's firearms, but they don't want to do that because they don't want to lose a fellow officer if this person is brandishing a gun when they open the door. And so they just say, okay, I know we have this red flag legislation in place, but we're just not going to do it. we're not going to serve orders, or we're not going to, So, I mean, this is a really complicated area, but it's one where, the implementation piece of it, even though it's the most important, falls by the wayside because oftentimes there aren't resources and oversight of how a policy is implemented.
Mhm. Yeah, that's good. And then, as we wrap up here, I know Ben mentioned that we're talking to a state senator next week, but, most of our listeners are moms in our community and other high school kids. And I was just wondering, is there any piece of advice that you have for them to kind of take action in our own community, per se?
Yeah, there's a lot that you can do to take action in your own community. I mean, you can be trained on how to identify people at risk, so you can participate in different trainings, so that you could be trained as sort of like a peer, somebody who can deliver interventions or who can, try to intervene with people in crisis. So that's one thing you could do at the or you can get in touch with the health department or any other leadership in your state or community that where you have recommendations on how to improve things. I mean, I think that you guys have a lot of knowledge and you're learning even more. And so knowledge is power. And you shouldn't feel afraid to go to these people and make recommendations based on your experience and based on your community's experience. And oftentimes people think that they know what works for young people, but you guys actually know because you're young people. So you can let them know what your needs are and what you would like to see done and in place. And I think by doing that, you would be playing a big service to the people who grow up after you and who are living in your community. And so I think that, is my recommendation.
Mhm. And that kind of reminds me, we did a teen mental health certification at one of our local mental health centers, and I think that's something everyone should do. I think it was very helpful. It was only like, one afternoon, few hours, but like you said, I think finding those leadership roles or just being educated, I think that's definitely what we can do, starting tomorrow. So.
Yeah, and I found one of your responses to one of the previous questions. Like Ben was asking about the impacts of packages of policies as opposed to seeing how various factors intersect. And I know you were talking about your research. So kind of as we wrap up, I think my final question is, how can people kind of get involved, not get involved, or how can people access research like this, contribute to research like this, stuff that's so important to help us understand, particularly how policy intersects with mental health. How can people find out about this, and through finding out about and supporting this research, particularly your research, where can people find that, and uh, kind of help build support for that kind of activity, research activity?
Thank you. For our specific research, we have a Center for Suicide Prevention in our Bloomberg School of Public Health. And so on our website, we will have some information about various things they're doing that are going on. But I also encourage people who are your age, if you find somebody who's doing work that really excites you, see if you can do a summer internship or see if there's some type of a role you can play. For example, I have two undergrad college students, and I had one from Duke and two from Johns Hopkins working with us on major projects over the summer. And these are folks who want to go to medical school, so they need experience. And so I would say just reach out to people that do work that inspires you and see if you can play some type of a role, whether it's even volunteering to get your foot in the door, but then also thinking about, um, you know, uh, maybe they have some kind of a fellowship program that could be very beneficial to you. It could be like an academic agency like mine, or it can be a community-based agency that's delivering services in your community.
Mhm. All right. Well, like Ben mentioned, we have another episode next week with a Illinois state senator, and then we have some more episodes planned. But Dr. Wilcox, thank you so much for your time. It was a great episode today. And yeah, my name's Ethan.
I'm Ben.
I'm Kabir.
And just remember, your mind matters.